Thank you, Liz. I appreciate that. And as Liz said, I'd be happy to take any questions as we talk. I really want the session to be an interactive session. So the title of the talk is Primary Care Strategies to Reduce High Blood Pressure in Rural South Asia, Designing a Cluster Randomized Trial in Bangladesh, Pakistan, and Sri Lanka. So this is a feasibility study that I'm discussing with you to design a full-scale trial in the 3 countries. And the study is funded by the UK-based funding agencies, MRC, Wellcome Trust, and DFID. And these are the partnering institutions. We are the coordinating center at Duke-NUS. And then we have the ICDDRB in Bangladesh, the Aga Khan University in Karachi, Pakistan, the University of Karachi in Sri Lanka, and the London School of Hygiene and Tropical Medicine in the UK as the partner institution. And so, so just to give you the background, so you know the data from the Institute of Health Metrics and Evaluation formed this exercise on the global burden of disease. And the successive global burden of diseases data will show us ranking on attributable risk factors for mortality. What are the causes of death and what are the risk factors for those causes of death? So if we look at that for the year 2010, high blood pressure is a leading attributable risk factor now for mortality and for premature mortality globally. So this is true for all over the world, not just for high-income countries, but also for middle-income countries, and for many low-income countries as well, except for perhaps sub-Saharan Africa. So this is true, and even in the sub-Saharan Africa is going up. So it will be somewhere, where it is in 1990 that you see is the 4th leading cause of death. So I think we don't have a clear picture for the region, because I don't have it separate ranking for sub-Saharan Africa, but it will be just about that, because infectious diseases are still very, very common there. But for the rest of the world, and if you take the world as a whole, this is what the picture looks like. It's high blood pressure, number 1, smoking after that. And this is true for many countries in South Asia as well. So if we focus on the 3 countries that we're talking about, Bangladesh, Pakistan, and Sri Lanka, smoking and high blood pressure are the top 2 risk factors leading to premature mortality in that region. And so other population characteristics in the 3 countries, they're populous countries, Bangladesh and Pakistan. Population is about 160 to 180 million. Sri Lanka is a little bit smaller. It's still predominantly rural, although progressively urbanizing, but you can see that it's still predominantly rural, about 70% on the whole. Population lives in rural areas. And life expectancy is in the high 60s. Sri Lanka is a little bit higher. And there is a little bit, although all 3 are low middle income countries, there is a little bit of an income gradient, Bangladesh being the poorest, Pakistan in the middle, and Sri Lanka doing a little bit better. It's a smaller country, higher life expectancy, more economically well developed, but they're all low middle income countries. But what you can see uniformly is the age standardized death rates from non-communicable diseases. So you can see NCDs are the pendulum has shifted. Most of the deaths in all 3 countries are from non-communicable diseases, and which is true for the rest of the world also, right? So, and from cardiovascular disease, almost 1/3 of the deaths are from cardiovascular diseases. And we know that there's a very, very tight relationship between blood pressure and cardiovascular disease, and I guess that's what you saw on the first slide, is that most of the deaths globally, the number 1 attributable risk factor is hypertension. I think that's what explains it. And the prevalence of hypertension, if you look, is also uniformly high in all these countries, accrued and the age standardized death rates. If you look at population age 18 and older, about 15 to 18% of the population. If we look at slightly older adults, middle-aged, age 40 and older, about 1 in 3 adults. 1 in 3 adults in these countries will have high blood pressure. That's very high. These numbers are pretty comparable to what's happening in the developed countries, and this is not what people had expected. I mean, people are thinking 20 years back or even 10 years back, but you think about developing countries, you'd have malaria, you'd have infectious diseases. But like I say, as you're seeing, the pendulum has shifted. It's hypertension, and the estimates on the prevalence of hypertension. If you look at the surveys, the national health surveys, the community surveys, they were showing a rising burden, not just in the last 5 years. This is happening over the last 2 decades, and I'm going to say that repeatedly when we come to the next slide. That this has been a slow and gradual process, and despite the process, despite the rising burden, the governments hadn't done much. So high blood pressure and other non-communicable diseases have been neglected. And if you look at the policy level in these countries, if you look at the national policy or even the provincial policies, were the governments doing anything? And so non-communicable diseases are only recent additions as far as the policy documents are concerned. Really 2009, 2011, or 2007, I mean, those are very, very recent additions. You'll see the draft 0 or the first draft and any provincial policy document or their national health policy documents. You'll see just these names emerging. They don't have a very clear operational plan how they're going to deal with this as far as prevention or even management is concerned. If we look at the local high blood pressure treatment guidelines, many of these countries will not have any, and the ones that they're fairly dated. Right? Pakistan will have one from 1989. I mean, it's very, very dated, right? Likewise, they don't know how about addressing comorbidities. Really don't have a plan. Do the budgets have a line item for prevention? There isn't one. And so obviously, because these are all either recent additions or they really don't know, there is no operational plan. So you'll go to the primary care clinic in these countries and you ask the general practitioners or a midwife or a healthcare worker, they really wouldn't know how to manage hypertension. They wouldn't know what drugs to give. They wouldn't have a plan. There's no screening because really at the national or the provincial level, they have not highlighted, they have not built any capacity. They really wouldn't know, right? There'll be a huge variability, right? So that's what's happening there. So the community workers in these countries would know, they'd be able to tell you how to manage malaria. They'd be able to tell you how to manage, malnutrition, do growth monitoring, do family planning, because that's on their health agenda. That's the mandate. And some midwives will be able to tell you how to manage pregnancy-induced hypertension, but that's just about it. For other non-communicable diseases, for diabetes or hypertension, it's not there. And we've shown you already. I'll go back to your first slide. What's the number one risk factor for mortality now is hypertension. And how long have we known this? We've known this. I showed you the slide from 1990. It was number 4 already in 1990. So we've known this now for at least 3 decades, that it's going up and we've neglected this, right? So something needs to be done, right? So now that these countries have put it on their agendas, they know they're keen, they want to do something, right? There was a UN high-level meeting in 2011 where there was the member states, the WHO member states have agreed that there's a target setting that's done that they have to decrease NCP mortality by 25% by the year 2025. They have to reduce the prevalence of hypertension by at least 10%. So now they're going to have to report back to the WHO and say they're going to be out there. Well, there is this expectation that there has to be some accountability, but how will they do that? They don't know, right? Is there an evidence at the public health level how to move forward, what to do when there is no capacity? So there's very little evidence, right? Now we conducted this control of blood pressure and risk attenuation trial in Karachi, Pakistan, and reported this. This was done about trial was initiated about 10 years back. We planned this and reported this 3 years back. And so this was a trial, a cluster randomized trial in urban Pakistan. And again, to answer the questions of can we better manage high blood pressure at a health systems level? Can we improve care, delivery of care? And what we tried was, and this is a cluster randomized trial, and the two interventions, a factorial design. And the two strategies that we evaluated were home health education by community health workers. So in developing countries, we have these community health workers who go door to door to deliver family planning services and some immunization and some maternal child health services. But like I said, they don't have a mandate to deliver any NCD services or any non-communicable diseases preventive care. And so we said, okay, fine, what if we model a program and say, can these community health workers go and deliver some preventive services for non-communicable diseases? We know that some of you will be from the medical background, so now we know this DASH diet approach, increasing physical activity, eating a healthy diet can prevent and lower blood pressure, so non-pharmacological approaches. So if these community health workers go home and increase awareness and deliver messages on non-pharmacological approaches to prevent and manage hypertension and advice on improving adherence to antihypertensive medications. And if we go and train the community GPs on updated management of hypertension, so we know that their guidelines are dated, but if we, and there are no regulations on continuing medical education, but if we train the community GPs, is that going to make a difference? And so this was a cluster randomized trial, and so this was a factorial design study, and factorial design was either single intervention of a trained GP only, or a single intervention of home health education only, or then combined, so the intervention of home health education plus trained GP. And then there were 3 clusters to no intervention or usual care. So they were just in those clusters, the individuals were going to their community GPs, and they were not receiving any home health education by the community workers. And so there were 3 clusters in each. This is the N of the hypertensive individuals in each cluster. And after 2 years, what you see here is the decline in systolic blood pressure from baseline to follow-up over 2 years. And so over 2 years, we observed that blood pressure decreased in all 4 groups. And this is generally what happens in trials. So you recruit patients and you follow them up. You don't do anything, still the blood pressure goes down, right? So we observed this in the no intervention group as well. Blood pressure declined. And in the single intervention group also, blood pressure declined, and there was no difference here. So really no effect of these interventions. But in the combined intervention group, we saw this, right, a marked decline, and we also observed an interaction between the two strategies. And the interaction P was significant at 0.003. And the difference between the 4 groups was also significant. So this was a greater, this difference was about 5 millimeters. So this was the intervention effect, or the treatment effect, was a greater decline in systolic blood pressure by about 5 millimeters of mercury, which is clinically significant, clinically meaningful difference. Yes?
It's a very interesting study. I'm just quite surprised that, there's just a comment that just having home health education as well, educating them about blood pressure is not actually having that much of an effect, or having a trained GP, but combined as an integration, it's making a difference. Would you like to maybe elaborate more on that? Why do you think that's happening?
Yes. So this is, we wondered why that would be. And if you go back and you look at the literature as to what happens with single interventions and what happens with combined interventions, what have the studies in the West shown? And in fact, there's a very nice systematic review which was published after the study was published. The single interventions, you will see that single interventions for blood pressure control have not shown any impact anywhere. When you combine interventions somehow, And I think what was happening here, so let's see what was happening here. And I think what was happening here is that patients were going to the GP, getting the advice from the GP. GP is telling them, okay, you need to take your medications, you need to lower the salt in your diet, you need to take fruits, vegetables, whatever. And then they'd go home. Then the community worker would come and the health worker would say, you need to do these things. She'd reinforce. There's a lot of reinforcement, right? And I think and that's what happens when you combine interventions, is you get this message from here and you get a reinforcement from somewhere else. Then you go to the GP and then you go to the physician again, oh, you must do that, right? And I think so I think it's probably true not just for blood pressure control, for other outcomes as well. Right? You go to your doctor will say one thing, and then you'll get a call from the nurse or somebody else will come and say and reinforce those things. Oh, you must do that, right? That has an impact. Otherwise people forget, especially when it comes to non-pharmacological and especially when it comes to adherence. So I think that was creating the synergies there. Okay?
So are the GPs primarily providing advice, or they are giving drugs? And is there a distinction between a decrease from the lifestyle and a decrease from the drugs?
So very good question again. And we looked at the adherence. And in fact, a student of mine of maths who's doing a master's did a separate analysis of people who were going to train GP. She'd give MEMS bottles to them, which is a medication adherence monitoring devices. And she looked at adherence to antihypertensive medication. And people who went to train GPs, adherence to antihypertensive medications did improve. So although this was a packaged intervention and we weren't powered, with packaged interventions, we really couldn't tease out what was because of the medication and what was because of the advice. But we've done some other studies, embedded studies within it to sort of give us some clues, and adherence improved. So I think it was a combination of things, but some of it was antihypertensive medication, some of this was advice, some of this was a combination of it, right? Okay. So that's what we observed, so this worked in the urban setting. These were all private providers, right? And I think it answered some of the questions for the urban settings in Pakistan. And after this trial, we did a formal cost-effective analysis for this, and this combined intervention was also found to be cost-effective. But some questions remain unanswered. And so what are the unanswered questions? We wondered whether effectiveness of these strategies would generalize to rural areas in Pakistan, right? We did this in Karachi. Would it extend to rural areas with somewhat different population and health systems characteristics than the urban areas, right? Rural population is a bit different. The rural provider characteristics are different. Would strategies to manage hypertension integrate into the public health infrastructure? Now, we intervened only on the private providers, and the community health workers were also sort of private contractors recruited by us. These were not. So we just created like our own model program and said, well, you could this works. But when we used the lady health workers, the publicly funded lady health workers, and asked them to go deliver the same message, they had their own things that they had to do, would it work? Would it have the same effect, right? And so that's a question. Would these findings extend to other South Asian low middle income countries? We think that they would, but would they really, right? Would the strategies be cost-effective and potentially sustainable in the above settings, i.e. in the rural areas in Pakistan and in other rural South Asian low middle income settings, right? So these were unanswered questions. And so that leads us to a feasibility study. So the overall objective of the feasibility study is to gather preliminary data to optimize our intervention. So we know we have something to work with. We know that if we train GPs, we know that if we provide the home health education because of our model program, and we do that, combine that, we have something, right? But how do we integrate that, right? And how do we modify that for the rural setting and extend it into 3 different countries, right? And then assess its effectiveness in the public health infrastructure. That's the question, right? So we have to optimize the interventions and design some strategies to reduce, and that can be integrated in the primary care infrastructure in rural communities in Bangladesh, Pakistan, and Sri Lanka. And we will also evaluate survey instruments and protocol. And as we venture out to do this, right, we want this our multi-component intervention to be successful, right? And what are the principles we have to bear in mind, right? So any intervention that we assess has to be applicable to the local context, right? So ours was applicable to that we evaluated before to the urban context. Now we're going to the rural context. Would it be acceptable to the stakeholders? And who would be our stakeholders? Would it be the patients, the providers, right? The funders. Funders mean the people who would potentially continue funding these strategies after the life of the project. We do an intervention. What if we show that this is successful? And after this is successful, who is going to continue funding this? So maybe it could be the government, it could be other people, it could be the provincial government, so the people in the ministry would be important, the village leaders would be important. They'd have to say, yeah, okay, so all of those people would be our stakeholders. So whatever interventions we're doing, we'd have to get their buy-ins, right? Even before we intervene. Sensitize them. Ideal to use existing infrastructure if possible, right? Because it helps you a lot. You don't want to go and build parallel structures. Parallel programs are always most expensive. If you use the existing infrastructure, it saves you a lot of cost. But because your cost is always going to be marginal, you'll be only adding another component. I don't have to bring in new community health workers. I can use community health workers from the existing program. I don't have to fund new position for the doctors. I don't have to bring in my own vehicles, right? I can use theirs and piggyback our component onto theirs, if possible, right? From the resource standpoint and cost standpoint, and that brings us back to the cost effective and affordable. And these are two different concepts, right? Cost effectiveness is something, and you probably will study that more detail in your economics class, right? And affordability is something else, and you know the distinction between, I guess, between cost effective and programs can be cost effective, but not necessarily affordable, right? You see a good TV, it's good value for money, that's cost effectiveness, right? I'm getting some, right? But you just don't have that money. It's not affordable, right? So you want to keep the cost down, right, of the program, and that's important, so that it's affordable then. Right? And for all of those reasons, you want to say, I want to piggyback as much as possible. Sometimes piggybacking too much, if the existing capacity is stretched overall, it can be tough. Right? So these are the things that you've got to balance and think about, right? And that will bring us to the next point: feasible and sustainable in the long run. So it has to be feasible. They have to say, people will cooperate with you. Stakeholders will say, okay, here's the thing: this is a tough program. I just don't have the capacity. My manpower is already stretched. I have no room to accommodate anymore. My lady health workers are working 200 times, they're working 120 hours already. There's nothing, right? There's no more room. The mental health folks are coming and saying, piggyback my program, right? Somebody else is coming and saying, piggyback my program. How can I do this, right? So yes, go ahead.
And going along with that, how accessible are the health community workers and even medical centers around rural areas in Pakistan, Bangladesh, and Sri Lanka?
Right, so how accessible means, so I think the community health workers are very accessible. There is one for most households in the rural area. So they are the frontline not help in terms of prevention, disease prevention, workers, and they are very successful in all three countries. And in fact, not just in these three countries, but a lot of low and middle income countries. They're in China, and a lot of countries in Africa, you had these concepts of barefoot doctors. They're not really doctors, they're, the village workers. And so they are very accepted by the communities. They're there, they live in the communities. They're actually from the communities. A lot of people are queuing up for these jobs. There is a training requirement, and so they do that. Now, there are some challenges with these positions, and sometimes they don't get their salaries on time, and so there are these issues. But people, people are queuing up for these. These are empowering positions. So there is no shortage generally of the community health workers. There are places where there's shortage of physicians, but not of community health workers. Right? So let's come back to the next one, right? So I think, paying attention to this, we designed our objectives for the feasibility study. So the first one is to seek broad stakeholder consultation for sustainable integration of strategies. And so we did this exercise even before the intervention, and we'll do this after the intervention. And we'll come back to this in great detail, who our stakeholders were and what we did with them. Our objective 2 for the feasibility was to train the providers in locally adapted strategies for reduction and management of hypertension. And so this one was, we've got the curriculum. So this is, obviously, the question was, for this one, we did a COBRA intervention, for example. We trained the providers before. There's a home health education curriculum for the community health workers. There's going to be a curriculum for the physicians. The community workers will go and measure the blood pressures and all of that. But these curricula had to be adapted to the local settings. The diet in Bangladesh is different from the diet in Pakistan, is different from the diet in Sri Lanka. The fruits are different, their practices are different, the phrases that they use are different. So all the curricula had to be adapted to the local context. So although the key messages, the standardized messages had remained the same, so the amount of salt is going to be the same, the amount of fat and the types, so those things will remaining the same. The way you prepare the food and what we are recommending is going to be different for all 3 countries. So that's what we did in objective number 2. Is first we adapted the curriculum, then we had to train in the feasibility. Then it was, can we train the health workers, and then assess their competencies? Are they trainable, right? Can they measure the blood pressure? These are all questions. What's going to be, can they accurately measure blood pressure, right? And then we'll check their inter-rater reliability and show and demonstrate, and their competency and the skills. Yes, they are able to do this, they can do this well. And then same thing with the physicians, right? We're going to prepare the curriculum, and then we're going to train them, and then we're going to assess their competencies in the rural setting, because these were all questions in our mind. And can we do this at all 3 sites? And will our results be comparable, right? So can right? Then we would test the interventions and the strategies and the referral system. And then of course we had to come up with a referral system. So how is the community health worker going to be referring to the physician, and what's going to be the referral loop, and the checklist that they're going to maintain, and the tracking system. And so we had to develop the tracking system. And is that going to be uniform, and what they're going to be, and how is that going to be tweaked in the 3 countries, and is there going to be a difference? So all of those things we had to come up with. And then finally, and then pilot test that. And then the 4th one is to implement it, and then to conduct a cross-sectional survey with a limited longitudinal follow-up to determine the utilization of strategies once we piloted this. So coming on to the first objective was getting the stakeholder feedback. And who are our stakeholders? So our first stakeholders are the high-level officials, and this is what we did. These are the number of interviews we did in the 3 countries. So the high-level stakeholders were really the ministerial level people from the health ministries in the 3 countries and the finance ministries. And why did we go to the health ministries and the finance ministries? Well, we had to get their buy-ins, right? They had to, we shared with them, this is what we want to do, and we wanted to sensitize them. And so this is, I think we had, it was a dual objective: A, advocacy, Bring them on site, let them know this is what we want to do, this is a feasibility, this is successful, we'll come back and do a full-scale study. If we were to do a full-scale study and we show that this is effective and cost-effective, are you going to be willing to fund this? Do you think you can sustain this? Once the project's over. And this is a question, is it going to be high on your agenda? Are you going to be an advocate? Are you going to go to the central ministry and advocate for funds? And we got an excellent response, and which is from all three countries, because it is now already on the agenda. We saw that it's in the policy document, so it was a very useful and a worthwhile exercise from our point. And from each of the sites, and especially from Pakistan, I think we got the feedback. Please try to keep this as low cost as possible. We will, because this is the one thing that the provincial ministers will look at and say, if it, obviously if the question of affordability came up, if the cost is high, is going to be challenging, and then you're going to need a champion who will move the agenda forward in each of the countries. And then questions about, and I'll come back to that when we talk about what components are included, compensation, are you giving any extra compensation for the services? What, we don't believe in extra compensation, how are you packaging that? So I think we got some very, very useful suggestions from the high-level officials, but overall, it was a very useful exercise to sensitize them, to get them on site, to get the buy-in, and to get their commitment, political commitment from them, which I think we got from all three countries. Then our other key stakeholders were the district level managers, the private providers, the public providers, community health workers, their family members, patients, and then we also interviewed the pharmacies for availability of supplies. And pretty much the public providers, the private providers, the community health workers, yes?
I'm just curious, so is that the number of interviews, like the household, like 3 interviews per household?
So there is no magic number.
Okay.
Right? This is a feasibility. When we go on with the full-scale study, there will be many more.
Okay.
Right? I mean, there really isn't, but I think we just wanted to get a sense. And we said, right, I mean, we'll do 15 per country in the feasibility. I think this is relatively few still. When we'll do this in the full scale, that will be at least 25 interviews per country. But this is just to get an idea of how things were. And I think we conducted the first 3 or 4 interviews, and we were getting pretty much the same answers. And you sort of get an idea, it's the same response, you say, okay, stop. You sort of saturated.
So the areas you were focusing, so in
Yes.
Pakistan it was Karachi. Were the areas kind of similar in different?
Okay, so let's come back to, so these are rural areas.
Mm-hmm.
Okay, so in Pakistan we were in Tata. In Bangladesh we were in District Hangal, and in Sri Lanka we were in Kurunagala. So these are all rural areas. They're about 2 hours away. Each one of these areas is about 2 hours away from a central metropolitan city. So Bangladesh site was 2 hours away from Dhaka, Pakistan 2 hours away from Karachi, and Sri Lanka 2 hours away from Colombo. So they're all pretty much similar in terms of distance from your major city. And the interviews with the stakeholders were basically focused on, so what are they focused on? They're focused on, do you think strategies are useful? What do you think are the facilitators and barriers? So they're going to give us the suggestions. What are your existing practices? What are the facilitators and barriers? And pretty much we got a very overwhelming response of, okay, we think the community health workers and the providers were excited. We think we can do this. They didn't focus so much on extra compensation. The challenges that they shared were workload. We are very busy. We just will have to see how it's going to fit in with our existing workload. That was the one thing that I think we heard from all the sides. But everyone was, we want to be trained. The community workers said, I think this is going to empower us. and elevate our status in the community. The household, the patients thought this was the best thing. Because they were saying, we don't get this care, it would be very helpful if the community workers can come and measure our blood pressure at home. Oh, absolutely, the doctors need to be trained, because they didn't have any faith in what they were doing. And so, yes, the district managers had some concerns about, they wondered whether the capacity of the community health workers was sufficient for them to be trained, and so whether they'd come up to the competency would come up. And so for that, it was very important for us to sort of demonstrate that, yes, we can bring your skills level up. And then the objective assessments of competencies, and I think, so, and then they were concerned, and they were adamant, they're saying, yes, oh, that's fine, we don't want you to make any compensations directly. So there was, and then there's a lot of discussion on compensation. There's a lot of workload, and this is extra services. I think some compensation would be important. So I think that's what we heard. So just to summarize the challenges were home screening of blood pressure would be most challenging from a workload perspective. The district health officers communicated that level of training, if you don't give incentives or compensation, then they thought it would be challenging. So they needed some kind of compensation, but how that was channeled was a question. They didn't want it to be given directly, and workload. And from the community workers and providers, they were saying workload will increase, but it'll be manageable. And pretty much each one of them said, we can manage this with teamwork, it'll be managed. Challenging with current workload, but manageable. So that's what we heard from each one of them. And then it was training, and as far as training was concerned, so let me share with you how this went about. So first was coming up with the treatment algorithm. So this was a treatment algorithm. I'm not going to go into the details of this. It's essentially, depends upon, we had to keep this simple enough for the practitioners to follow, but based on evidence, right? So yes, so you cannot have two different sets of standards, and it has to be consistent with the most recent international guidelines. So your NICE UK and the JNC8 as much as possible. And so that's what we did. But whatever drugs were available, and so ACE inhibitors, calcium channel blockers, diuretics, they're all generally available in the private pharmacies, and so they're included, and based on there is this risk stratification, and they'll get a statin, which is again in accordance with the recent management recommendations, so not just blood pressure control, but overall approach for cardiovascular risk reduction. And so that's what this is, and we did an extensive comparison of what we are recommending here with what the current guidelines are, and we had to make sure that each one of our steps that we are recommending is consistent with your most recent recommendations of NICE, European guidelines, American Society of Hypertension, JNC, and WHO, and you'll see that there are subtle differences in what the guidelines, so no one agrees with one another, but our recommendations are most consistent with NICE, and where we had to make some adaptations for keeping it simple in the rural areas. There we said, okay, then we'll go with some other guideline, but we had to base it on evidence, and we couldn't just oversimplify it and not follow our guideline, and so that's what we did. And again, this also is recommendation for statin use, and again, it's we couldn't use. Most people are recommending either a computerized risk scoring. We couldn't do that. That's not possible in the rural areas where sometimes there's power outage. And there are no computers in many of these clinics. Most of these clinics are not computers. So those kinds of things, high tech, will not be possible. So we have a simple scoring system where they can just look at sheets and say, if you're this age, diabetes, heart disease, stroke, or current smoking, we'll just start you at statin. And if there's a move towards starting all hypertensive on statin, even that wouldn't be wrong. And so we are doing some level of risk stratification, and that's good enough. So that's what we're doing, and it's consistent with the international guidelines. So that was our hypertension management. For home health education, again, it's a standardized messages using culturally sensitive behavior change communication strategy, takes into account local diet and language. This training conducted over 4 days by nutritionists, epidemiologists, and clinicians. We have an extensive nutrition and lifestyle curriculum, which, I've shared that with you, and these are basically maintaining nutrition, maintaining ideal body weight, physical activity, smoking cessation. We talk about alcohol in the Sri Lankan manual. We don't talk about alcohol in the Pakistan and the Bangladesh curriculum because of local sensitivity. Again, we had it initially, and then we were advised to take it out, and so we did. It's not that alcohol is consumed in those countries, it's just not appropriate to talk about it. It's underreported, and we listened to what people had told us, so we took it out. Yes.
You mentioned that using some sort of technology poses a barrier. Has there been any consideration for using things like mobile technology, or how prevalent technology is in this area? And can it be utilized as an already existing platform kind of thing?
Yeah, so I think mobile technology is used for communication. So the health worker will make a call for referral in the referral loop. So she will use it for making a call to speak with the community health supervisor or to refer a patient, but that's just about it. We are not using it for text messaging, for example, to patients because of the literacy rate concerns. And so I think there are ways around it, but right now not in this because of those issues. Yeah, but it's used in some contexts. Yeah, I mean, I think it's a brilliant because they routinely use it to communicate, to refer patients to the hospital. So this is a communication loop again, right? Just in time. And so this was also developed in consultation with them. And so when we went, we said, this is going to be so complex because how are we going to develop this? What do we base this on? We struggle with this. There isn't a monitoring referral mechanism. And we went to Pakistan, we were talking to them and said, you must do something. What do you do for TB? Right? I said, yes, we do have a tracking system. We have a beautiful tracking system for TB. We have a beautiful tracking system for growth monitoring. I said, well, that's what we will model it on. Turns out each of the country has it for infectious diseases. They just don't have it for non-communicable diseases. So they were very familiar with it, right? And it's always helpful, right? Because they understand it, right? They use that system, they understand it. We said, right, so let's just, can we use the same for hypertension? And that's the kind of thing that we model it on. So hypertension, so community health worker goes home, identifies, the patient with hypertension, fills out the form, the checklist. The checklists are an important part, right? She fills it out. She said, this is what I did. This patient's hypertensive or not. This is what I delivered, home health education. Refers this patient to the trained provider. Trained provider will manage the patient, completes the checklist. The checklist gets registered, deposited at the district health office. We have these designated hypertension care coordinators. They have TB coordinators. We said, yeah, we need to have a care coordinator. It's important somebody keeps a track of what's going on here with these hypertensive patients who are coming in, right? Somebody has to take charge. So we have these designated hypertension care coordinators, and they ensure that these patients are, they keep a track of the checklist, make sure these patients are seen, and the checklist coming from the community health worker gets matched with the healthcare provider's checklist, and the ones who don't match means those patients have not come, will be followed up by the supervisor. So we have this, we've created a mechanism for tracking and follow-up, and then our staff will collect these checklists for them for sort of quality assurance. So we've developed this mechanism of tracking and follow-up and referral. And turns out this mechanism is working right now in all of the 3 countries. They're familiar with it, they think it can work out, and they've modeled it, and they've identified the people in the system. We had extensive dialogue with the district health ministries, the providers, and it's working, yes.
What's the success of the referral from the hypertensive patients to the providers?
Hypertension here?
So I'm guessing, do the community health workers, they go, is it
So
their
community health
contract to go around regularly to monitor them?
So community health workers will go and they will see the patients, and if the patient's blood pressure is above a certain threshold, they say, you need to be evaluated, you need to go and see the doctor.
You need to go to the doctor.
You need to go to the doctor.
So what's the, I guess, rate of success of patients who are looked at as, okay, you're hypertensive by the community health worker, and to actually go to the provider?
So that's what we will find out.
Okay.
Yeah.
And on that note, so I know many people have classes and things starting at 1. So would it be
Oh,
yes.
okay.
Yeah.
Okay, then, right, so quickly, so then this is what we've come up with as a full-scale study, right? So based on what I've discussed with you, we have the strategies, right? We have BP monitoring by community health worker and referral to provider, home health screening by trained community health workers, training providers on evidence-based management of hypertension care coordinators in government clinics, and we've also added compensation for additional services, because this was a strategy that they suggested. And so this is the package intervention, which we are now testing. We propose to test in a full-scale study. The full-scale study will be in 30 clusters, 10 each in the 3 countries, 25, 50 individuals, age 40 and over, versus usual care, which is the 15 clusters. So 15 clusters to the intervention, 15 clusters to usual care. This is the randomized trial stratified by the countries. We will collect data and based on an outcome assessment over 2 years, and there's going to be a qualitative study where we'll do the stakeholder interview, and we also have a cohort patients to understand hypertensive patients' experience during the course of what we're calling this a multi-component strategy in relation to components of intervention, diagnosis of hypertension, treatment, and quality of life. I'm just going to go through the next few slides and then I'll take questions. So the primary objective of the multi-component intervention delivered by a primary care infrastructure is more cost-effective compared to usual care in lowering BP of adults with hypertension in rural communities. So that's our hypothesis. And we're seeing it lead to a greater reduction in systolic blood pressure after 2 years compared to usual care, overall expected mean difference of 4 to 6. Right. Ancillary question, is the MCI better than usual care in improving medication adherence, lowering BMI, dietary sodium, smoking rates, lipid levels, and inter-heart cardiovascular risk score? And this is a risk score, the CVD risk score that's been validated in this population. And then to understand the patient experience, which I just had discussed with you in the course of MCI, this is a qualitative study. And this is the design. So we have the strata at the country level. Right? And then we have these clusters, the 10 clusters, 30 communities for 3 countries, randomized either to the multi-component intervention or to usual care. And if you want to look at the data hierarchy, so, I'm not going to go, we can talk later about the sampling, how we're sampling the villages, but basically there's one major health clinic in each village, which is a unit of randomization. And the analysis will be done at the level of the patients. But then they're seeking care from this clinic, there are many clinicians, there are these community supervisors, there are these households, so there may be some additional level of clustering, but that's what we are doing, so unit of randomization is there, unit of analysis is going to be at the individual level, and I just want people to understand that there is this level of hierarchy in our data. Primary outcome is change in systolic blood pressure at 2 years. Secondary outcomes indicate BP control to target, and an individual and composite outcome of death or hospitalization due to cardiovascular disease. Within 2 years, we will do primary cost effectiveness measure, incremental cost of blood pressure reduction from baseline to end of follow-up, and the incremental cost of projected CVD diaries. And then primary cost effectiveness measures, secondary cost effectiveness measure is an incremental cost of quality gain from baseline to end of follow-up. And then we have the fidelity measures. The fidelity measures are key in a study like this, right? So we're looking at the proportions of providers and health workers trained We are looking at proportion of planned home health education sessions delivered at the household level. We are looking at proportion of patients referred by, this is the question you were asking, CHW seeking follow-up with providers, right? We are looking at proportion of screening treatment checklists collected from district office. And what will this tell us, right? What this will tell us, let's say we do the study and we find blood pressure didn't go down, right? We'll at least be able to say, we then can go back and look at this data and say, did we actually implement what we were supposed to implement, right? And if we did, we said, right, we got the checklist, we trained everyone, this is what happened, and or let's thought experiment. It actually worked in Pakistan, it worked in Sri Lanka, it didn't work in Bangladesh. We'd have all this data, from all the sides. We'd have questions. Did you implement the intervention the way you were supposed to implement? That's fidelity. Did you train everyone? Did this with the checklist? Did you do? And if you don't have this information, then you start wondering what happened. Did they do what they were supposed to do or not? Was the process right? And if you don't have this information, then you just don't know what happened, right? You just keep on speculating, say, I think they didn't do this. But if you have all this, you say, they did all this, it's just, it doesn't work in Bangladesh. This is not for them. If you don't have it, you say, they couldn't implement it. Right? So you can say a lot. So this is vital. This is very, very important to have. Fidelity is important in implementation research. Right? Although you'll have some people saying, just let it happen. This is a pragmatic research. What do you care? You're just looking at effectiveness at some level. You don't care whether they did it or not. You're looking at the effects. But I think this is key. Right? And then the qualitative study has two components, the stakeholder interviews, and this is what we talked about, right? We will do a lot more. We will do like 25 each in each country. And then we will have the focus group, 3 to 5 per intervention cluster, 10 patients per focus group, 3 cycles over 2 years. And we'll ask them about adverse effects, logistics about treatment, sustainability, motivation, patient perceptions with label of hypertension. So this will give us some idea about, you got diagnosed with hypertension, what was your experience, what do you think about being treated, and all of those things. Trial governance, we have a trial management committee meeting, we have data safety and monitoring board, we have scientific steering committee, national and international advisory committee for dissemination. And our sample size, in each country, we have about 50 participants. In each cluster, we'll have 85 hypertensive cluster, equal sizes due to same number of clusters, similar cluster sizes in each. And then these are our power analyses. We're not doing sample size analysis for logistics reasons. We know what our sample size is going to be. Then we do a power analysis. Our main intervention effect, we have a conservative intra-class correlation based on our previous work and work of others is 0.02. And a sample size of 30 clusters, 85 individual cluster, we have a dropout rate of 20%. And we have a lot of power for our main overall effect, which is pooled all 3 countries together, right? And then we have a stratum effect specific. So this one is going to be all 3 countries together. Then we want to know, okay, let's do this analysis separately for Pakistan, separately for Sri Lanka, and separately for Bangladesh, because the countries will be very interested in what happens in my country, right? And we have, with the same assumptions and with the same dropout rate, and we know also if one of the clusters drop out, so we did all of that, we have about 90% power. Interaction effect, what if it's different, right? What if in 2 countries blood pressure declines by 9, and in one country it declines, by 6, or in 2 countries, or something like that, or in one country it declines by 3, and one country by 6. So we have enough power to look at these interactions, and we've done a bond for only correction for that. So for 10 clusters, 85 per stratum, right? More than 90% power. And this is our power curve for the interaction effect. And maybe Liz can talk a little bit more about this at some point with you guys. So with the 20% dropout, you'll see the sort of, the green one is the full sample size, and the other one is the 20% dropout rate. So we've got sufficient power to look at the interaction. There's a planned sample size of 50 individuals from 3 countries, 10 clusters per country, consisting of 85 patients per cluster, is adequately powered to evaluate primary hypothesis at the study level, the country level, as well as differences in the intervention effect between countries, so the intervention effect. Analysis, I said, is an individual level analysis. So we look at, evaluate, estimate confounding interaction effect, ICC, possibility of finding missing data. We'll use GEEs, and cluster effect will be run. We'll also do sensitivity analysis, just a little bit too detailed. Sensitivity analysis will be a cluster level analysis, which refers to a small number of clusters. And I think that's enough for what we have. Any more questions?
And maybe we'll first thank you, because I'm sure I'm sure you will take, I know some of you need to go to other things, so please do, and I'm sure you'll be happy to answer any questions, but if you need to leave, do go ahead. I think Gary has another question.
I'm curious about kind of the economic background of the different communities, and I understand the goal of the health worker is to monitor and to deliver the education. But is it, I don't know how to ask one, but what is the means by which these people can then go ahead and make that change? Like, is that food, are they able to pay for that food that they need? Kind of just getting a sense of the background.
Yeah, so it's a good question. So I think regarding the food, right, so what do we do in the behavior change communication strategy? So I think the goal of the home health education and the BCC here is to work with their budgets, right? So we don't recommend anything. We try not recommending anything that we cannot afford. We're not giving them money. The study is not providing anything. The study is not providing any food. The study, we're just providing them advice. So the community health worker will go to the house and say, well, and I think we have it very detailed. When we worked in Cobra, and this is what we did in the main Cobra in Karachi as well, and we'll follow the same strategy here. We don't say you gotta go, DASH diet will say, 5 servings of fruit, vegetables, this, that, the other. We don't do it like that. That's our goal. That's our target. You go to a house, you ask them, what are you taking? They say nothing. We can't afford any fruit. They're expensive. Despite these countries are exporting agricultural countries, right? But the local, they don't make it for the local market. They're exorbitantly expensive. So you go to them and say, okay, but you cannot afford that. But can you maybe have a kitchen garden? What else can you do? There must be a seasonal fruit. There's always a seasonal fruit that's cheap. You have them think this through. What can you do? And it's the way you talk to them. So you make them answer. You give them leading suggestion. The stuff that you do in motivational interviewing, and this is the way you talk and say, okay, all right, but can you maybe, okay, what? And it's amazing how the household members and the patients will come up and say, I think I can do that. I think I could get this. Oh, that's something I had. So we'll say, all right, fine, maybe you can make that change. So from 0, you'll go to 1. From 1, you'll go to 2. So it's baby steps, and we'll see a change. And what we saw in Cobra, and we actually published this, that the consumption of fruit, vegetables went up. And we didn't give them any money. And so I think if they're able to make that change during the study, they should be able to continue. So that aspect is taken care of. Expenditure on medications is also out of pocket in the 2 countries, in Pakistan and Bangladesh. What we are telling them, the providers, is to provide low-cost generics. So that's the switch that they're making. The source of information on medications for these physicians as the pharmaceutical rep. So, we tell them, please do not prescribe the branded medications. So I think So that's the other element here. So if they continue that, then I think it's a win-win. Now, what will be needed? Yeah, what will be needed here is perhaps an extra community health worker, perhaps funding that hypertension care coordinator, because we are giving some money for that. Right? So nothing comes for free, right? And I think that's why we are going to the government and saying right now and sensitizing them, you will have to invest something. Right. And so are you serious about this? If we were to hear from them, there is just no way, I'm not interested, this is not a priority for our country, we would not work in that country. That's why we're going to them now, in the feasibility. If you hear them, if Bangladesh said I'm not, or Pakistan says, no, this is not going to be our priority, we have different priorities, we would pack up. We are not going to waste our time.
So kind of following up on what you just said, it seems like the greatest burden is going to lay on the healthcare workers and the capacity for them to get the training and education needed to educate the people as well as build a relationship so they can encourage them to make these lifestyle changes. Not necessarily for the study, but in order to make it feasible and sustainable. Has there been any consideration to go outside the government to other sources of funding to build capacity so this can continue?
Yeah, so I think there are 2 or 3 ways that this can happen. So how would an intervention continue in a country like that or in low-income countries? So one is through the government sources. Other sources would be you tap on donor agencies, and sometimes, and a lot of things move when money is coming from outside. You can have, World Bank can give loans and they're matched. So that's one example. What we want to do here is, so I think those things, yeah, you've got to show that the model works, and then, when these agencies will see a change happening, then they'll come. But the government has to be interested. And you have to show that intervention work, and but going to agencies like that is certainly on the agenda. And DFID, who's partnering with us, has a development focus, so not just a research focus. So that's the developmental agencies to give. They're generally time limited, but you see a change. What happens with that is just you build capacity. And that's how capacity for malaria was built, and that's how capacity for malnutrition was built. It was through donor agencies.
Two questions, not all related to that one. So maybe a government can express interest in taking on the project after the project area of chapter is done. But then do you have any suggestions or advice on how likely the government is going to take on the project, or how they do to make it more?
Yeah, I think there are 2 or 3 ways that the government will participate. One is if they see a donor is given, right? That's always welcome, and so that's one way. The other way is getting a champion within the government, so getting them interested. How you get them interested I think there are no right answers. Something clicks, you sensitize them, you go to them, you talk to them, and if you get a sympathetic ear from someone, if someone's generally in these countries, I have to say, if someone's relative is suffering from the same disease, I think in all countries that's true. Then they tend to have, sort of more sympathy. But you need a champion. You need somebody who says, I'm going to fight for this cause, or I'm going to advocate for this cause. Somebody has to be passionate about it. And money always helps, right? So somebody says, yeah, I've done this is working in my area. So that's one. The third one is always, I think what we're trying to do, I think devolution, what's happened in Pakistan and also in Bangladesh, is is working in different provinces. We show that it's working in the province of Sindh now, Balochistan, which is the other province, and Punjab, which is the other province. A comparative exercise. And the comparative exercise is very good. It's helping us with the project. When you do a multi-country project, you tell one country, the other country has done this, you will see an improvement. You show them the mirror, right? Showing them those kinds of approaches work regionally. Those kinds of approaches will work within the country also. So I think you tell Sri Lanka, this district has done well, that district has done well. You get all the district coordinators and the district leaders sitting on the same table, and you show them the results. You'll see an improvement the next time, and you'll get the buy-in. So I think we're going to try those strategies.
Yeah. And so once the government officials decide to take on the project, do you follow up on that, or how do you consistently check on that if they're taking it to another direction?
So we have a national advisory committee. So I think we are thinking along those lines from the get-go. Our national and international advisory committees for dissemination is more for dissemination. The national advisory committee will exactly be for this purpose. For keeping them on and for taking the agenda forward. I think what our thinking is for this is we have the model that our sites will now become the model sites. The people there we are trained will become the trainers. The community workers there, the providers there, they can then become the master trainers. And sort of, we move on to other things, and they continue and develop the program further in the country. So we expect them to come up. Our study coordinators who are helping us with this study, where we expect that over the years their roles will be elevated and they will lead the program in their respective countries.
So are they going to be hired by the project or hired by the government?
So I think there can be different models of doing this. So once this is done, it could be a jointly, but let's say different decides to take this on, right? The different to fund their provisions for a substantial amount of time, and then the government comes on. It could be if they match the funds, then there can be so many different permutations and arrangements. But the project, the agenda moves forward and scales up. We want this to scale up.
Yeah.
But and clearly people with a lot of experience with this will then assume the leadership position as we go on and do other things.
Thanks so much for continuing to talk with us probably into your lunch break. So the last of us, we can thank you again very much.